Welcome everybody to the IDRPP Early Echo. We're glad that you're here today. We are asking that if you'll put your name and contact information into the chat, and if possible, turn on your cameras just as a way to get to know everybody over this virtual learning session that we have. We hope that you enjoy our echo sessions. We ask that you ask questions, so put those into chat. I will make sure that we monitor those. But as always, just protect individual privacy. So avoid using identifiable markers like first, middle, last names, addresses, those kind of things. If you have any questions, you can reach out to a hub member. They all have or will now all have an asterisk in front of their name, so they are easier to find in that chat. If you've never attended an echo session, welcome to your first echo session. We're glad that you're here. Echo will always have three components. We have the first one is, again, just getting to know all the amazing colleagues that we have on this call. And that's why we ask you to put your contact information in there, ask those questions, turn on your camera so we could get to know everybody. I always love when I see Janelle Boyer on the call because her name is spelled exactly like mine, and it makes me so happy because that never happens very often. It's always an LLE or something else weird. So anyways, it's just a way to get to know people through this virtual thing. And then we will always have a didactic presenter or a subject matter expert. And today we're really thrilled to have Pat Boyle be talking to us about tethered oral tissue impact on function. And she stepped in when one of our previous presenters had a conflict, and so that's where we're having her fill in for us today. And she's keeping her slides out because we all know technology sometimes doesn't work all that great. And then the next portion of an echo is a case presentation where we will then go into small breakout groups, and everybody gets to share their expertise and knowledge and information on the subject. So don't jump off at the very end. Stay for those case presentations because you guys all have such amazing insights and information. I love hearing everything. We also come up with recommendations that we send back to whoever did the case presentation. But they're also useful for all of us to go back and look at. I know that there are times that ideas have been given during those breakout sessions that then I go back and pull them and I'm like, oh, I can use that with this family that I'm working with today. So it's a great way to just get more information. If you can rename your profile, or if you have questions about how to do that, please just reach out to me and I'll help you do that. We ask that you fill out these surveys. The surveys will be dropped throughout today's session as well as the PowerPoint in chat. The surveys are what we take back to our funding agency to say, here's the stuff that we do within this echo session and a way that we can keep that free. In order to get a certificate of attendance, the survey needs to be completed. There's also a section or a question on the survey that asks for your address and contact information. The reason why we ask for that is we do send out swag and thank you gifts for doing that. So if you would like to receive any of the swag or a thank you gift, just please fill that out. Canvas is where we store everything. So the PowerPoints, the videos, any of the recommendations, handouts that we get. If you would like access to the Canvas page, please just email earlyecho@usu.edu and we'll get you an invite to that Canvas page. Again, I just love those case studies. So if anybody has a case, a case discussion, a case narrative, whatever you want to call it, so it's not sounding so scary, please consider submitting a case. And again, you can just email earlyecho@usu.edu and we will get you set up on the schedule. They're a great way to, again, like I say, learn from all of you amazing people on the call. We're all out there doing the same work, and so it's a great way to hear new information or to just get some brainstorming on some of the tough clients that we work with. And with that, I am going to stop talking and turn it over to Pat and let her take it away.
Okay, well, I didn't even turn my mute off. My name is Pat Boyle, and I have stepped in at the last moment. This is a presentation I've done 2 other times. One was to the early intervention group, OTPT speech nurses, and I think special educators at DDI Vantage. And then I recently did the presentation to the Utah Physical Therapy Association group, and that was nerve-wracking. Who knows why is a PT doing this sort of stuff? So anyway, let's jump in and talk about tethered oral tissues impact on function. Oh, crumb. See, I should have practiced. I can't advance it.
Oh no, it won't. Yes, look right there. Now move see your little arrow button,
Uh-huh.
go down,
Yeah.
go over right there.
So that's not how I do it on my computer. But anyway,
Oh,
you can
well,
just
I don't know, Pat. I'm
I
just
can be messed up so easily. So how do I get all of our pictures out of here? Oh, there we go. I do that. Okay. So my goal here with this group is to explore what we as early intervention therapists, nurses, and developmental specialists can do to facilitate decision making in TOTs management. Explore who do we refer to when there's a TOTs concern. And the biggest thing I want to focus on is to explore the diagnosis versus function versus treatment. So I've had a journey with this, and the journey's been ongoing and long because you do doubt yourself when this kind of thing is not part of your scope of practice, and then you have to make it your scope of practice. So why would I be concerned with what's going on in the mouth? Well, to begin with, the tongue is a muscle. It's the only muscle in the body with one insertion. And I really would like to get all of you people out of my way. There, it just doesn't work. There we go. It's not working. So I guess I'm going to have to do this. Okay. As a pediatric physical therapist and feeding specialist, I've become increasingly aware of just how impactful the restricted oral tissues can be. And I've always looked at the fact that TOTS is a thing. And it's there, you're hidden. Okay, TOTS is a thing, just like a hip flexor contracture is a thing. Both have the potential to impact function, the function of mobility and stability in order to execute the movements of eating, breathing, talking, walking, running, and kicking. So if walking, running, and kicking aren't impacted, why release the hip flexor? If the baby is breast bottle feeding well, has normal vocalizations and typical mouth posture so that the mouth is closed at rest, tongue rests against the palate, and the baby breathes through their nose, why clip? So keep all of those things in mind. So my experience with TOTS is pretty broad because I work in the NICU. I work in the NICU at primary. I've done consulting in all the other NICUs with Intermountain here, and I also go to newborn nurseries up here in Heber and Park City. I have seen TOTs in early intervention, and I get referrals from the normally developing community, babies that are having trouble with breastfeeding. So what is this? Tethered oral tissues is a term used to describe tight, restrictive connective tissue between oral structures. This connective tissue is called frena, and everyone has it. But when this tissue is thick and it's tight and it restricts typical movements of the tongue, lips, and cheeks, there's a tie. You can have lip ties, tongue ties, and cheek ties. and they fall under the umbrella of TOTs. Identification of TOTs is important as these ties have the ability to negatively impact a child's feeding skill, proper facial structure development, breathing, sleeping, and speech and language development. So the first one is a buccal tie, and it's interesting because it's literally on the cheek area, and they say buccal, I say buccal. It's a restrictive frenulum attachment from the cheek area to the gum on the side of the dental arch. And this is where usually the baby molar teeth are or will be located. Cheek ties connect the cheek to the bony ridge of the upper jaw. When the tissue impedes the normal function of the cheek to generate suction or effective seal around the nipple, we may release these ties. So there's a buccal tie. And they're pretty interesting because I think they're more impactful as teeth start to emerge because they can really pull on the gum tissue and make gum tissue recede. But they also impede mouth opening, posture, and positioning of the breast, nipple on the soft palate. Latch is narrow and shallow. And my guess is that they don't impede bottle feeding, but I don't really know. But I look at the difference between a bottle-fed baby and a breastfed baby, and the oral motor skill, the elevation of the tongue is so important in breastfeeding, whereas a lot of kiddos can get by with a fast flow nipple and chomping with a lot of gum compression. So these are your tongue ties. And this is what I've seen, this not low diagnostic criteria is one that I've seen in the literature. So they're using this to identify. And this one right here is the most dangerous. I've opened up kids' mouths and I've looked at this and I thought, what the heck is this? Because that's the tongue. That's supposed to be the roof or the bottom of the mouth. And there's just all this redundant tissue here. But the biggest piece and why this is so important is that the tongue is really quiet. The tongue has no mobility and it's got way too much stability, which may, with some of our genetic kids who have problems with airways, with their tongue occluding their airway, may benefit respiration. But again, I don't know. And then this is finally a lip tie. So you have again, your classifications. And this number 4 is a significant classification because it can really pull down that it can really pull down that upper lip and make seal on the nipple hard. So there is an upper lip tie, and it's mostly this is where the ties are. Anyone with a gap in their front teeth has had an upper lip tie. And the interesting thing about upper lip ties is pediatricians years ago would say, oh, they'll fall eventually and they'll rip it out. And some kids do. I've had people talk about that. So what is our frenula? Our frenula is myofascial tissue, and it's literally starts. Why is this doing this? It literally starts at the very tip top of the tongue and goes down to the tip top of the toes. And it's all interconnected. It's myofascial tissue that connects all of our tissue together. And so I'd like you to entertain why a tongue tie would cause all of these problems. I've seen it impact torticollis. I've seen it impact plagiocephaly, effective feeding, reflux, gut discomfort, which includes stooling, digestion, and a lot of swallowing of air. Once they transfer to mixed or hard food boluses, they have trouble with moving their tongue, moving that bolus into and swallowing it effectively, lateralizing their tongues. A lot of kids are irritable. They may ultimately have head and neck pain because of this constant torque on their neck. Again, you can have gum disease with that tissue pulling away at the tooth and tooth decay. The biggie is breathing. These kids often mouth breathe. They have seconds or periods of apnea while breathing at night, especially asleep. And then the biggie is their jaw development, which only impacts all of this even more. So the roof, if we keep in mind that the roof of the mouth is the floor of the nose, and the higher the roof of the mouth is, the narrower the opening to the nose is. And just as a functional ability, these children will open their mouths to breathe. The space that's meant for eating sound production is also being used to sustain life. And this is a pretty interesting progression of chronic mouth opening, which gives you a receded jaw, which you can become quite micrognathic as a result of this posture of the jaw. Um, so why do they occur? So the tongue develops in the 4th to 7th week of gestation. And in order to develop, it's fused to the floor of the mouth. The frenulum and gum tissues stabilize the jaw and the tongue and allow it to be guided forward to be developed. At about 12 weeks of gestation, cell death occurs, and the frenulum, which allows the frenulum to go away and allows the tongue to separate from the floor of the mouth and the gum to be freed from the lips, which allows for more functional movement. As the tongue differentiates from the floor of the mouth, small strands of thin tissue remain. We all have frenula. We all have upper lip, lower lip frenula, and some of us do have, little bits that are attached to our jaw and then under our tongue. These thin strands of tissue are midline, and they're under our tongues and on the gums. And the problem occurs if the fiber strands stay thick and restrict movement. So this is interesting that literature has reports the use of tongue tie as being recognized as an anomaly as early as the 1700s. It was routinely treated into the 1940s. A history of birthing techniques reports midwives keeping a really long baby finger so they could snip the frenula under the tongue to allow for better breastfeeding. However, once infant formulas were introduced, and you saw a decline in breastfeeding, you saw a decrease in tongue tie treatment. Prevalence of TOTs has been reported as high as 16% to as low as 0.3%. And there's many articles that cite 8%. Males are supposed to predominate, except I've seen lots of females recently. Kiddos with micrognathia, Pierrot band sticklers, and a variety of myotonic dystrophies have this oral structure dysfunction. And is it in the case of Pierrot band, does it help with respiration? Don't know. So a review by Rebecca Hill and Britt Pados, they're lactation people, states that without strong evidence in favor from 1997 to 2012, the incidence of frenectomy rates have increased 866%. So this is a hot topic. It's a topic that everybody seems to have an opinion on, including, I don't know if it was a New York Times or I think it was a New York Times that posted that article a year and a bit ago about how we are mangling up babies' mouths. So I'd like to introduce you to John. And Mom said this is how he spent the first month of his life. Extended, totally extended. And normal birth, normal pregnancy, he was 7 pounds, 15 ounces. He had body work, and then he had a tongue and lip tie release at a month of age. Mom says the breastfeeding improved, and prior to the release, breastfeeding had been painful. And she was an experienced mom. She had other kids, so she knew how to breastfeed. However, when I saw him at 4 months, his tongue was still restricted. He stooled about twice a week. They looked like normal stools, but he really strained hard to pass them. And I'd like you to think about what the tongue's function is in terms of burping, in terms of refluxing, and what do we do when we bear down to produce a stool? If you don't have good engagement of that tongue, especially the soft palate up against the tongue up against the soft palate, you have a really hard time closing off your airway and allowing things to pass. She reported that he transferred milk very quickly. He's gaining weight just fine. So, of course, the pediatrician wasn't concerned. So, lactation specialist Lisa Palladino, who I have followed, theorizes that typical mom-baby dyads, and this is normal dyads, respond to TOTs. The mom hyperproduces milk, and feedings are over in about 10 minutes before the infant fatigues with the abnormal movement of the tongue. So if you think that the child is doing a lot of chomping, they're not really able to get that good negative pressure on the breast to transfer milk, they're working hard. And thank goodness, moms have great letdowns and lots of milk, and they produce for that child. But let's look at John. He hated being on his back. When he loved to play with his feet, but certainly wasn't going to do it while he was on his back. So he rolled over to his side and shoved his fingers and feet in his mouth and trying to get him on his back. I think this might have been her month picture that she was trying to show. I think, yeah, it was his 3 month picture by the three muffins. He again preferred to shift his weight over to the left. And that was presumably to release, to go into the tension that was on his tongue. So this is this little guy and why he doesn't like his back. So he can't elevate his tongue to help with his reflux. And it was painful and he didn't like it. So good for him. So this is him on his belly. And he looks like a pretty normal 3, 4 month old, doesn't he? Everybody's going to say, yeah, he looks pretty good. But his mouth is open. Why is his mouth open? Mouth is open. And he doesn't have that nice chin tuck that should be coming in around this time. He really, really loved his belly because it allowed him to visually pursue his world, because on his back, he was overwhelmed with reflux. But this sort of shows functionally what this very, very normal little boy was doing as a result of his oral restrictions. Oh, mom was just about to say something. So I saw him at the age of 4 months, and I apologize for the picture. My dog was very concerned that he was crying. His tongue was still restricted, and the dentist did not want to resect until body work was done. And the pediatrician, of course, didn't see an issue because he was 16 pounds. Um, Mom wanted a second opinion. She didn't know what to do. She had the resources in Salt Lake City to go to, but she just wanted another opinion. So I did some cranial work with him, which he hated. Um, he's a typical baby, but has atypical reactions. When he first came in, mom was holding him. He had great smiles, great eye contact, but his mouth was open and he was drooling. She said he has reflux with lots of wet burps, and again, the pooping just once or twice a week. His symptoms were that he loved to stand, won't stay on his back, flips over to his left side, arches when placed in sitting, hates the car seat, loves his tummy. He had good weight through his arms, but again, no poorly initiated chin tuck, and his mouth was open a lot. He had very guarded movements. He postured in extension when he was held, and he resisted body work until I started in on his pelvis, and then he melted. After my treatment, he went home, and I know as I handed him back to his mom, I thought this kid is really calm. His body feels calm. And she did report that he stooled daily. She went after and got more body work to have a second release. And she sent me a picture of him the other day. He's 2, and he typically eats. He eats typically, and he talks a lot. But mom wonders if some of his speech quirks are because he is 2 or because of his previous tongue issue. She says that they all reported that he's got a big tongue. And I think the releases helped with better movement. Okay, so how do I evaluate a baby? If I go into the newborn nursery, I unbundle them, I wait for them to transition into an alert state. The evaluation is always before the next feeding. I just look and look and look and try and start up a relationship before I make the baby mad. I test their tone and reflexes. I look at their anti-gravity responses. So I suspend them on their bellies. I look at their lateral righting reactions. I see whether they take weight through their legs. I look at all of those things. I look and see just how they deal with supine, side lying, and prone. And in prone, especially if their head is turned to one side, I'll turn it to the other side to see if they will then pick it up and look over to the other side. And then I get into their mouth. I look at their non-nutritive suck. I look at their lateral writing of the tongue, posture of the tongue at rest, whether it elevates, where the tongue is when the kiddo's crying. And the tongue should not be on the floor of the mouth. It should be either midline or elevated beyond midline. And then with the baby's head in my lap, I really get in there and I look at the palate, I look at the lips, and finally under the tongue. And they hate it. But you have to dig. You have to get in there and dig. And generally, it's the dad holding the flashlight and me digging. So these are some of the resources that I've felt have been beneficial to me in the past. I love Robin Merkel Walsh. She's got a real good perspective on this, as does Catherine Shaker. I actually talked to her a couple of months ago and I said, do you think tongue tie impacts the quality of the birth? Do you have more kiddos with meconium aspiration? Do you have kiddos that go on to full-blown hypoxic ischemic encephalopathy? And she said, that sounds good. She said, why wouldn't it? The tongue can't help with those first breaths, and especially if there's reflux involved, elevating up against the soft palate. So I'd like to investigate that. So I want to always focus on function over form. So the head ultrasound, the MRI will show horrible bleeds and brain damage, but the kid is walking, talking, and relatively age appropriate. The same applies to the TOTs physical exam of the mouth. It reveals if the baby is breastfeeding well, good before and after weights, good milk transfer. I think function overrides what the TOTs looks like. Again, they don't all need intervention. It is function being the driver. So these are the assessment tools that I use. I really like Martinelli. He just looks at the tongue, but it's a score. And I think people are really, really interested in the tongue much more than the other ties on the gum and the lip. But other people like the Hazel Baker, uh, and they give you a score, and then you can use that score and talk to your pediatrician and go forward. So my first is I've got 3 case studies that I wanted to talk about, all with different issues. So this guy's name was Augie. He was a 2.5, almost 3-year-old with multiple developmental delay. And when I looked in his mouth, I saw that grade 4 tongue where all this tissue is under his tongue, and you're going, what the heck? He had no sounds. He was constantly vomiting and he smelled. That was mom's definition of him. He would use a sippy cup, but he'd place it between his left molars and he chewed the fluid down. Just this bite, bite. It wasn't chewing, it was bite, bite, bite the fluid down. He would not chew and really restricted his textures. He also didn't do any hand to mouth, didn't do any self-feeding. He was fed. He was fed, and it was the spoon in his mouth, scrape it off his tongue. Swallow. No movement, just swallow. Um, my takeaway with this was just because you had an undiagnosed genetic issue does not mean improvements can't be made. And I wanted to install this into the presentation, but I'm sure there's copyright issues. There were 4 little kiddos with cerebral palsy, and Robin Merkel published this, and they all had varying degrees of ties. And when you look at the result before and after, so case 1, the sleep improved, better feeding, less shoulder and neck tension, looser hips, less TMJ popping. And these are older kids. These are 7, 8-year-olds. And I can send you the referral. It was done in special care dentistry, and the title was cerebral palsy and ankyloglossia, improved sleep, speech, swallowing, and breathing after tongue tie release. And it looked at these 4 kids, and the quality of their life was improved drastically. Case 2 had less mouth breathing, decreased nasal, easier to breathe through the nose. A lot of them were respiratory, except for case 4, none was reported. But as far as speech, they all were, three of them vocalized better, easier with a g sound. I don't know why why is the g sound easier when your tongue can move? So these are the kids that I was afraid of. I'm still kind of afraid of them. But why can't they show difference? Then there was little Hazel. She was a totally normal little baby, full term, and then diagnosed with significant severe liver disease requiring a transplant, and came home with an NG tube, and she had a bad posterior tie. And we worked and worked and worked and worked and worked with her. But do you cut? I'm not going to advise it. This is a child that was immunocompromised and was getting labs done every week just to make sure that her rejection phase was okay. The pediatrician was interested. Everybody knew about it, but she ended up with adaptive abilities to learn to eat functionally. But there's no way I'm touching something like this. And then finally, there's this little one who had a full-term traumatic birth after a traumatic pregnancy. When I watched her breastfeed, she was there for 45 minutes with no transfer or minimal transfer. When I did an evaluation, she had a really, really bad lip tie with a grade 1-2 tongue tie, which indicate wasn't a 4, but it was enough that it decreased her tongue movement. She also had other comorbidities. She just had a lot of issues, but today at the age of 2, she's running around, still has some issues with some speech and language, and feeding, but she had improved transfer from the bottle and the breast once she had a release. This is a baby that I saw after 36 hours old, and you can definitely see this pretty thick, thick, thick frenulum here under the tongue. You can see that she was a typical baby. Mom's milk wasn't in yet, and they'd given her a little bottle, but it was taking her an hour to transfer 12 mils, which with a normal suck, she should have transferred it. She had decreased lateral movement to the right. She was a really sweet, normal baby who did not know if they needed to eat. She'd had only 5% weight loss, 10% allowed, her sugars refined. And we got her on a bottle. The pediatrician said he wasn't going to do anything because he wasn't going to do the frenulectomy. He wanted to send the baby off to an ENT. So everybody was aware. And there's her lips, not as significant as the tongue. So here's my case study, and we can all talk amongst ourselves. She's literally as a child I've seen in the last month. And she was referred to a feeding specialist and physical therapy for feeding and movement issues. She was born at 38 weeks. She was a twin. She was about 4 pounds, 12 ounces. She's now 15 pounds. So no, are you worried? She's 6 months old. Are you worried about her weight? No. But she's got a twin, and she's always been 2 pounds smaller than her sibling. She's had chiropractic for torticollis. Multiple practitioners had mentioned her tongue tie. And mom reports that she's always been more stiff than her sibling, and she doesn't cuddle easily. They transferred her onto goat's milk for the reflux. Interestingly, she has a left-sided mouth droop, and she leaks milk on the left. Her tongue clicks with feeding. She's on a bottle. She has a very loose seal on the bottle, lots of nasal snorting, sometimes nasal regurgitation. She's really tight and restless when eating, and she only takes about 3 ounces compared to her sibling who takes 5 to 6. And she gets really tired with feeding, ultimately taking the 5 ounces. She was only stooling every other day and had lots of gas and abdominal distension. Now, I saw this kiddo because she doesn't live in my area. Well, she lives far away. I saw her on Zoom, and I could see the functional feeding abnormalities. I could see that in supported sitting and standing. She had this head tilt to the right, and on her back, her head was to the right with weight through the right side. She does attempt midline with head tilt, but has lots of extension. She kicks her legs, but won't play with her feet. On her tummy, her head is rotated to the right. She can activate to lift up and tracks toys to the left briefly, but prefers her head to the right. Um, Facilitated rolling is better over her left shoulder than her right, and she struggles with excessive trunk head extension over the right. So mom noticed all this stuff, and everybody kept saying she's gaining weight, she's fine. So the therapeutic interventions, initially I said, let's try some thickening, add some prune juice to stool daily. I wanted her more upright for feeding to decrease any kind of diaphragmatic pressure because she was really struggling with reflux. I then asked her to do just some gentle pressure on the tongue, like literally at the base of the tongue, to try and suggest to the tongue that it could elevate better. And then also bottle position the mouth to engage the tongue. So you can shift the nipple up to the palate, you can push down on the tongue, and then asked her to encourage left side sleep during the day. And then showed mom on Zoom some of the movements that I wanted on her pelvis to encourage hands to feet. So this is her when she's eating, and the noises are sibling. So she's just restless, restless, restless. And this is with a thickened feed, which mom said initially was okay, but her belly is distended. She's got a lot of gas and she's really uncomfortable. Mom tried to pull this down, but her she tires again after two or three. The mom's doing a little bit of the tongue help under her chin. And it's not jaw control, it's tongue. So it's no jaw, but it was just to say to the tongue, can you help me out here? But on Zoom, I saw all of the motor movements, but I needed to look. And until I looked, I didn't know for sure. And so I looked. We got together and I saw that her palate was high. She had that little bubble shaped palate, which meant that in utero, her tongue wasn't up and engaged and helping that palate smooth out. She lateralizes her tongue to the left, not the right. And her left tongue musculature was really tight, which was probably why she was drooling out the left. She couldn't capture the milk and direct it back. Whoops, whoops, whoops. What else did I want to say? So the oral exam revealed an anterior tie, upper and lower lip ties. And there's her little bubble palate. There's her lower lip tie. And whoops, I know I had more. Come on, Pat. There's her tongue tie. And I really tried to show the palate again. Okay, so this is day one of release. This child hated spoon feeding, never put anything in her mouth. This is the day of her release. She is moving and moving and moving and saying, oh, that feels so good, and pushing that thing over to the left. So it's like, ooh, I've got some releases here. I can move, I can move. And then this is her bottle feeding, day 3. Mom says she's calm, she doesn't move around. She's draining a 5-ounce bottle. So she's not tired anymore. And her, the quality of her suck still needs to be worked on, but she's got a lot less tension. So this is her 13 days after the release. That tongue says, ooh, I need to move. So my references, I think they're overrated. If you want any information, just let me know and I can let you know. There's many, many opinions out there from various organizations on the efficacy of treating TOTs, including the American Academy of Pediatrics. I think the speech and language group has come out with a policy. Obviously, ENTs have come out. But my focus is individualized approaches to any and all children evaluated for TOTs. Should look at form versus function always. And then these are our discussions. So I'm going to stop sharing, Janelle?
No, leave it up for a minute just because you have those questions right there. I'm
Oh,
gonna
okay.
open it up and see if anybody has any questions for you.
Okay.
So if anybody has any questions, you can put it in chat or just come off mute.
And I can't see anybody. Oh, maybe if I change this, I could. Yeah, there we go.
Can you just ask someone to talk to their pediatrician about this and they have the credentials to look into it? Or will their pediatrician not be able to help them with
So what was the
these tasks?
question? It's kind of,
Right.
Sorry if you can't hear me. I just was wondering if you could tell someone, oh, what if your child has a tumor lip tie? Just talk to your pediatrician. Is that not enough?
well, the problem is you can talk to your pediatricians. And the pediatrician I work with here in Heber is excellent. He says, yeah, Pat thinks it's there, it's there. But that doesn't mean that every pediatrician is going to agree. And I've had pediatricians disagree with me. Charlie's pediatrician, she had exposure to 3 different pediatricians and she kept asking about it. And they go, yeah, she's got a tongue tie, but she's gaining weight. So they weren't worried about it. They weren't worried about her drooling out the left side. They weren't worried about her excessive gas, excessive nasal regurg. And if mom, I think, had not had a twin, I don't know if she would have had been as empowered to go after this. But nobody gave her resources to help her. And so I think my job as an evaluator of movement and function is to say, it's impacted, it's not impacted. You can talk to your pediatrician, but most of the kids I talk to have talked to their pediatrician. And so that's what sends so many people down that, alternative route, which is, oh, well, maybe if I, saw my body worker, my chiropractic, or my whatever. But the real thing is that you need to guide your, children. I've had excellent conversations with ENTs. They're the same way. They don't recognize a posterior tie. They don't think the posterior ties are as impactful. They will clip an anterior tie, but to me, they're looking at the structure. They're not looking at the function. And that's where we come into play is we need to support the family and help them find who they need to find. So,
Yeah, I appreciate that, Pat. There's also 2 questions in chat. So one is that from Jennifer, and she says, I have a child who was diagnosed with a tongue tie, and mom is waiting to get it clipped. Any ideas of how to help her understand the sooner the better? He's barely eating and is very underweight.
yeah, that's kind of emergent as far as I'm concerned. Depends on the age of the child. These are the kiddos that I used to see in my practice that we went on and did an NG tube and then put a G tube in. And lo and behold, so if you look at the study with children with cerebral palsy, the majority of them, if they indeed had G tubes, what would their trajectory have been, given that the fact that they've got cerebral palsy? If they had had some oral restrictions released, would they have been more efficient eaters? So I think again, it's empowerment. I don't know where, Jennifer, I don't know where you live. I don't know how old the baby you're talking about is, but I am not one size fits all. It's very individualized. But I think losing weight, not eating well, that's an emergency.
Yeah, and I know she says Davis County.
Yeah. Well, there's the Utah breastfeeding group up there. What are they called? So she can get a referral, or no, she can just go, just call them. It's the Utah. I always forget what they're called. I've only referred a ton of kids to them. But if you're in Davis County, they're right there. It's called the Utah Breastfeeding and Tongue Tie Center. They charge. If you go to a dentist who's experienced, they will go with your dental insurance and or charge a lower rate. But again, these are emergencies. So I don't, so what is she waiting on? A practitioner to do it?
Sorry, I'll just unmute. Yeah, she had an appointment. At first, her pediatrician told her there was no tongue tie. She took him to a pediatric dentist. He said, yes, there is a tongue tie, but now she just doesn't really want to do it. I think she's just scared to do it.
Yeah, well, it's daunting. I agree. It's daunting. How old's the child?
He's 18 months.
That's hard. I mean, that's a hard age. And the dentists are quick. They certainly have children that are older than that. And the bottom line is it's the parent's decision. And if the pediatrician sees enough weight loss, might put in an NG tube or go for a G tube. I mean, so it's always a balance, you know. And so in your EI practice, do you have speech and language pathologists who are good at evaluating mouths?
Yeah. Well,
Yeah.
I haven't called them out. We do have an OT that she's worked with that, does agree. So yeah,
Just,
maybe we'll call.
just, you know, take pictures and look at function, you know, is the kid lateralizing? Do they tolerate, you know, solids? You know, do they have sleep apnea? Do they mouth breathe? I mean, all of these things are impactful, I think, in a child's life.
Yeah, I would agree. Certainly impactful. I know, Pat, you and I have been having discussions. So, my daughter has a tongue tie, and we only discovered this when she was, 15, and the dentist finally said, well, she's just not going to be a good kisser. But as Pat and I have been talking about this, um, like I went and asked her, Pat, is she exhausted after eating? And she goes, yeah, that's why I don't love meat because it's too hard.
Of course.
So, but nobody ever brought that up. So I think that Jennifer, to your point of like the sooner the better, yeah, the sooner, because now she's a young adult, that's a scarier, she has to make that decision versus me. And she was a messy eater her whole life, and we just attributed it to that's who she was. But it's really probably a lot of things that Pat has talked about in this.
Well,
So.
she's messy because she couldn't collect the bolus efficiently.
Right. And she didn't have a tongue to lick her mouth either.
Yeah.
So,
And exactly.
right.
Exactly. There's so many other things that go into this, but again, I want to emphasize the individuality of all of this. It's so important.
Yeah. The other question is from Jessica, and she says, coming from a mom who has been told that her 2-year-old daughter's upper lip tight isn't doing anything for her functionally, but just had recent tonsil and adenoids removed, mouth breather, gap in her 2 front teeth. Should she have her dentist release it?
I'd also look under her tongue because Lisa, the lactation specialist that I follow, says if you've got a lip tie, you more than likely have some tongue restriction. And that's just from somebody else. Those are statistics from somebody else, not me. But look under her tongue, you know.
And see, right, all those things about form and
And
function.
a secret for looking under the tongue for older kids is you hang them upside down
Oh,
and the tongue will fall. So gravity will make that tongue move. And you can see, because I can get into a mouth. That little guy, Augie, I got into his mouth and was able to get in and under. It's because he didn't have any strength in his molars, but your typical child will have plenty of strength and they will nicely bite you. So hang them upside down.
hey. Any other questions that we have? Tori, are we good for breakout groups?
Yes, we are. Is it
Okay.
okay if I just tell the hub members which question that they should
Yep.
talk about fast?
Yep.
Perfect. All right, so Heather Waters, you're in room 1, and I would appreciate if you could tackle the first question up on the screen right now. I would read it off, but I think it'll be faster just to let you guys look at it while I talk. And then in our second breakout room, Shelby, can you talk about the second question up on the screen? Leo, you're in our third breakout room, and I'd appreciate if you could talk about the third question up on the screen. And then lastly, Pat and Emily, you will be in our fourth breakout room, and I'd appreciate if you guys would talk about the last question up on the screen.
Okay.
Does this work good for everybody?
Yeah.
Perfect. Then I will start the breakout rooms.
Okay, well, welcome back. So I'm going to start with Pat's group. So Pat, I don't know who took notes or who, not you. Who was it?
I took notes.
Okay, Emily. So give that one idea from your guys' breakout. You had, if this is not in your scope of practice.
Yes, so we spent a lot of time talking about how it's not just referring to get a release if that's needed, but it's kind of a process, so there may be multiple referrals. So just kind of maybe sticking with the family, following up with the family. Okay, now because it's not just going to be fixed, right? There may need to be some retraining with a feeding specialist or lactation consultant or PT or OT. And so just kind of that follow up and multiple referrals. And it's not just going to be one appointment and not a problem anymore.
Yeah, and I love that following up with the family because I think that's where a lot of just that care coordination gets missed. And I know in another session, a family was really talking about how much they valued that, like to hear. They bring up a concern and they follow up a few weeks later or the next time I see them. So great suggestions. Heather, how about your group?
Yeah, so Kathleen took notes for us. Kathleen, if you're comfortable sharing out.
Sure. We had a lot. I've got a whole page of suggestions, but I hope this is the one that I thought of the most. It was because ours was, what do we do if the child has other medical needs that are being taken care of? So it was kind of like we need to prioritize. We need to let the parents prioritize that child's need. And this may not be very high on their list of things at the moment. So we need to meet the family where they're at. That doesn't mean letting it go. It just means letting the parent be in charge, deal with what they're, I mean, we're all human. We can only cope with so much, but prioritize that need, let the parents prioritize their needs and bring it back up again when they're ready, when they're feeling like they can handle this other situation that may be going on.
Yeah, and I love that. But we don't let it go, right? We keep kind of coming back with
Right.
it. Both of those things. Great. Shelby.
We kind of talked about a lot of different things. And I feel like I keep going back to lists. Like we talked about someone has a list of doctors and dentists in their area who treat any kind of tie. Having families make a list of different struggles that their child may be having that could be related to having a tie. And then having like a list of the common effects so that parents learn, maybe something that their child is experiencing could be related to the tie and they would have had no idea prior to that.
Yeah, I love that idea of lists and what could be related. Like I mentioned my story, as Pat and I were kind of brainstorming and talking about things, all the things that she was starting to say, I'm like, oh yeah, that's my daughter. Oh yeah, that. Oh yeah, that. Oh yeah, that. Oh yeah. Yep. Maybe I really need to have her think about getting her tongue tie clipped. So
yes,
that's a great thing.
Parents don't know what they don't know. So
Right. Exactly. Leo.
We actually had a question for Pat. We had some really good conversation, but I think since this might be a little bit, I guess it's just more or at least it seems to me that this might be a little bit more of a stigmatized topic. So we were just wondering, like with NICUs and stuff, right? Do they check for tongue ties with like every baby? And we're asking Pat that. Like, do they check for a tongue tie, like these providers or like these people in the hospitals? And would insurance cover like a procedure regarding these sort of things?
Well, I have had a baby in the NICU who required a revision or a release, and the ENT did it, but you're in a NICU. So every 12 hours is a different person taking care of that baby. So there's no continuity at all for that child. And the mother was there, but there was no stretches to be done. The kid had other issues. And yeah, along the way, we see it. We definitely see it, but there's really nothing we can do. You can refer to the ENT, but for me, there's other things going on in that NICU that need taking care of. So I saw a little girl years ago who was not going to breastfeed because her restrictions were so severe. She was functionally bottle feeding. The mom knew she had ties. I knew she had ties. I think some of the other speech therapists knew she had ties. I just gave her the resources. I said, once you go home, you find yourself a pediatric dentist who can help you out. Because that's where the acknowledgement is. I mean, I am not dissing the medical profession in any way, shape, or form. I'm part of that medical profession. But I think I think it's really important. And EI has taught me that over and over and over again. It's a team. It's a team. It's not just one single individual saying, there's nothing there. They have life and death that they're dealing with there. They're not dealing with functional restrictions. So a good example is a kiddo has club feet, is born with, deformities, and they're dealt with later. They go to Shriners later. The idea is the goal for a NICU is to get that kid out of there and get them home and let living start. So yeah, it's a hard one. It's a hard one. And so being resentful as a parent that your child wasn't identified in the NICU, you got to think about where your kid was. And they were sick.
Yeah.
Especially at primary. Those kids are sick.
Right. But I think it's also like you're saying, there might be other priorities that your doctor is thinking about. And so that's where I think part of our job is also to help advocate for families, teaching them how to advocate for themselves and that they are part of that medical team as just as much as they are part of our early intervention team. So I think that's a really good point, and a thing to remember. So I've dropped in the email. If you will all send your notes to earlyecho@aggies.usu.edu, we will compile those. They will be on our Canvas page for everybody to review and look and utilize those resources. Our session in October kicks off our starting topics around genetics, which Pat has also introduced today to us. So we will be having genetics just the start of the conversation, and then moving into our Prader-Willi syndrome. So hopefully we'll see you October 1st. I cannot believe I'm saying that month out loud. Like, what the heck? And if Marla says Christmas will be here shortly, I will just start crying. So have a good rest of your day, and we will talk to you shortly.
Thank you.
There is a question right there, Janelle, too.
Right.
It was,
So,
sorry.
yeah. Pat, there's a question that says, is there any chance that Pat can share a resource that we could give to parents that outlines your child may have oral restrictions and this is what it causes? Do you have a resource like that, Pat, that we can share on the Canvas page?
Not off the top of my head, but yeah, I mean, there's a really good pediatric ENT, and he had his own personal, let me just see if that's on the presentation. He had his own personal journey with ties. And he, what's his name? My brain is not working. But I'm just gonna, can I pull up my presentation here?
Uh-huh.
Let me just see if I can pull that. Oh, I can't. Reduce. Okay, here we go. Let me just look up some of, because it's in the resources. And he's brilliant. Oh gosh, where is he? Because I think I put it under. And
Is
he's
it Dr. Gahiri?
yes. Thank you. You know, when you get to be as old as I am, yeah, those kinds of things just, yeah, he's very good. Yeah. Is he on there? Yeah.
Yeah.
Yeah. Dr.
So
Gahiri so it's www.drgahiri Dr. GHAREAERI.com/resources. He's just a very kind guy, if that makes any sense. Now I can't get back into, you guys can still see me, can't you?
yeah.
Escape, then get back onto the Zoom. Okay, so he just has a lot, he's just a pleasant guy to listen to. And he is very, he really shuts down the shysters in the field because there's a lot of people that claim to know what's going on. And so, yeah, I like him.
And so, Catherine, also, if you didn't capture the PowerPoint in the chat today, it will be sent out in an email after today's session as well.
Yeah, and every single family has agreed that I can use their pictures.
You're so good.
Yeah, every single, of course.
Of course. Who doesn't want to share their cute kids?
Well, it's more than it's the learning.
I know it's the learning, but you also want to share your cute little kids' pictures too, right?
Yeah,
Because we all have the cutest kids ever.
of course.
Okay. Well, thank you, everybody. And we will hope to see you in October.